Welcome back for the final episode of LMU History Department's summer web social media series, Viral Histories. I'm joined today by Professor Devon Golaszewski, who is new to LMU this year. Professor Goliszewski recently completed her PhD in African history with a certificate in women's gender and sexuality studies at Columbia University. Her dissertation, Reproductive Labors, Local Expertise and Biomedical Legibility, Mali, 1935 to 1999, explores the history of maternal and reproductive health in Mali, with a focus on local women's specialists, the Malian health system, and gendered cultural practices. I'm not really doing it justice there, but that's as much as I can probably get into this introduction. Professor Goliszewski will be teaching modern world history this fall and courses in African history in the spring. Welcome to Viral Histories and welcome to LMU, Devin.
Thank you so much for having me. I'm very excited to be participating in this.
Great, thank you. A few weeks ago, Professor Carla Biddle spoke about the plague doctor, and one of the things that she mentioned quite briefly in her discussion was that the third wave of the plague, which was global in nature. So can you tell us more about the third global plague pandemic and how it was related to things like global shipping, trade, and population movement?
Of course. So we think of the plague really as a medieval disease, I think, in the United States, but actually there were several subsequent outbreaks of plague. And the third such outbreak took place at the end of the 19th century and the early 20th century. And I think it presents a lot of interesting parallels to what we are experiencing today in our experience of COVID-19. Perhaps not direct comparisons because the plague is a very different disease, most notably because of the insect vector that's involved, the flea, which is an important and necessary means of transmission for most forms of plague, such as the bubonic plague. But talking about the plague does, I think, kind of highlight different elements of the political aspects of public health interventions that we are observing in our own moment. So the third global plague pandemic, it began in 1894 in China, and it spread via these intercontinental shipping networks, moving from China to India to South Africa, Senegal, and other locations. And much like COVID-19 moved around the globe through airplane networks of people traveling on airplanes, this was also a disease which spread along intercontinental networks, as I said, shipping networks. And the first outbreak in Senegal, which is what I'll be focusing on today, occurred in 1914, and it arrived via the port of Dakar, which was one of the most important ports in West Africa in this period. It was the location where goods from all across the French colonies in West Africa were exported, and these included goods like peanuts and other raw materials which were very important for industrial production in Europe and elsewhere. Peanuts were used to make peanut oil, which was used in a lot of mechanical, in factory settings. And when the plague arrived in Dakar, it spread quickly to another major urban center in Senegal, which was called Saint-Louis. And there were two major outbreaks of plague in Dakar and Saint-Louis between 1914 and 1918. I'll be focusing on the Senegalese case today, but the disease is quite interesting because there was really kind of a global medical community response to plague. So as you look in different locations in India or in Hong Kong, you can see that there's a very similar public health response to the disease in different places. And this was partially due to the fact that the medical officers, the doctors involved, were part of the same professional networks. In the French context, the most important network was that of the Pasteur Institutes. And there were like locations of these institutes in all these French colonies around the world. And actually the plague bacillus was identified in one in Hong Kong for the first time. And I think that, you know, we're seeing today the kind of global medical community that we as non-doctors actually have a lot of access to in the way that medical knowledge is being reported. We can learn about studies that are happening around the world that really we're kind of seeing the creation of a global medical consensus happening in real time that we're observing. And that was something that was happening in a similar way with plague.
Very interesting. So, you're focusing on Senegal today, and Senegal was obviously a colony at the time of the outbreak of plague. So how did responses to the plague outbreak in 1914 thereabouts reinforce colonial hierarchies, especially around race?
They did so in a number of ways. It's probably one of the most significant dynamics of the public health response. And the first thing to really know is that the big cities in Senegal at this time, Dakar, Saint Louis, and a few others, were home to a multiracial population, and different communities had different political standings in colonial society. So in those cities, and I'll talk a bit more about the specific political character, I think later on, but in those cities, there were indigenous African communities, notably the Wolof and the Lebu communities. There were African migrants from other parts of Senegal and other parts of West Africa, because these were major shipping hubs, so people came to look for work. There were people who were part of a mixed race community, the descendants of African women, Senegalese women, and European traders who had marriages and romantic and sexual relationships in the 19th century, and who were kind of the political elite of these cities. There were Syrian and Lebanese merchants, and there were also Europeans. So they were very diverse places, but the public health response targeted different communities in very different ways. And some of the actions that public health officers, who were all aligned with the colonial administration, some of the responses that they took are similar to what we can recognize in our own moment. So they, required people to report to the health authorities if they had been sick. They mandated a quarantine, and in this case, it was primarily a quarantine that would occur outside of people's home in a special location called the lazaretto, which was a distinct space in which people could be quarantined. They vaccinated people. And once people had been vaccinated, they could receive a medical passport, which would allow them to move around the territory. And that's something we heard about a bit earlier in the spring, especially around the idea of an antibody passport, that someone who might have antibodies could potentially move and so forth. But they also undertook some actions that were different than what we have seen because of the nature of the plague, and primarily because the fleas that transmitted plague also fed on rats. They, tried to embark on some campaigns to kill rat populations. And they also destroyed people's homes and home goods that they suspected were infested with fleas. And they usually did that by burning people's homes. And in the latter case, and in many cases, these responses were, diverged wildly based on people's race and citizenship categories. So many of the interventions were mandatory for Africans, but optional for European residents of Dakar and Saint Louis. So in the case of Dakar particularly, the health officials mandated that Africans receive the vaccine, which was actually a very noxious vaccine for today's standards. It had very serious side effects, but for Europeans, the vaccine was optional. And so we can see that there's a, targeting of different populations, a level of kind of the coercive power of public health was applied differently to Africans than to Europeans. And people were very aware of that. They remarked on it, and they noted that that was a difference or they noted that difference between the experiences of different populations based on race. And one of the most notable ways that this was present was through the attempt to establish a sanitary cordon, or a cordon sanitaire, which was basically a model in which a more infected population would be separated from a less infected population. That's the public health idea. And the way that that played out in Senegal, and actually in many other places, was to try to establish a pattern of residential segregation between Africans and Europeans in Dakar. In Dakar, like a lot of other older cities, there was actually quite a lot of close cohabitation between people, African people, European people, people of mixed race descent, and their neighborhoods abutted even if people didn't live in the same neighborhood. But the French colonial state decided to create a separate community for some of the African residents in different neighborhoods that was farther inland. And they forcibly removed people from their homes, brought them to this separate community, and razed their homes, burnt down their homes. There was, a little bit of, let's say, distinction. I want to say, like, not all homes were raised because some homes were built in cement. So there's also a class element that occurred in this process. So most people's homes were built of wood or straw. And those were the homes that colonial officials determined that they could not easily sanitize, and those were the homes that were destroyed. So really the poorest Africans, their homes and belongings were often destroyed in this process, and they were removed from their homes. This occurred in Dakar and later in Saint Louis in 1918. And in another case, there was a community called Yoff, which is actually now part of Dakar, but at the time was a separate village that was distant from the city proper of Dakar in that period. And in that case, the colonial officials installed a military guard around the village, which separated the villagers from their fields where they grew crops that they relied on for food. And so actually you see in the aftermath of this sanitary cordon increased rates of mortality for the residents of that community because they were not able to have access to food, and the food that was provided by the colonial government didn't meet their nutritional needs in this very dire period. And I think that these examples are really heartbreaking because it's just incredibly painful to imagine losing your home in addition to the people who who might have passed away. And that's something that I think we should be very attentive to. The other kind of historical ramification of this process is that it really consolidated the residential segregation of the city of Dakar. So it kind of intensified a process that was already in place, and it was a model of public health intervention that relied on very racist ideas about African hygiene habits, about their ways of living, and the idea for a lot of colonial doctors was that Europeans were endangered by the cultural habits of Africans. Their health was endangered. And the bias implicit in that idea is very obvious in this case because plague is not transmitted in most cases from human to human. It's transmitted via an animal vector, and rats and fleas are not limited by a cordon sanitaire. They're not limited by any sort of residential segregation. So the process was based on an idea of individual behavior, and a little bit like an older idea of like the way diseases spread through miasmic transmission, that reinforced racial stereotypes of Africans for the colonial health officials who were involved.
Very interesting. You mentioned at one point the issues of class, and also in the village outside of Dakar, the ways in which the villagers were cut off from their crops. Was there a cohesive response between political and economic elites about the plague outbreak in colonial Senegal?
There was a lot of conflict about that, actually. So as I mentioned, Dakar is this really big port. It's an important location for export of various products. And the commercial elite a bit like today, was quite concerned about the economic impacts of different health interventions like quarantine. In the case of plague and in the case of other diseases like yellow fever, they were resistant to forms of quarantine. There's another very interesting parallel, I think, in the fact that a number of people, African individuals who worked in the city of Dakar but lived in other neighborhoods, would be granted passes to continue and go to work. So there's this cordon sanitaire in place. People aren't supposed to be moving, but actually people who work in Dakar are required to go to work and are allowed to do so. And I think that that has a lot of parallels to the way in which we have labeled. I'm sorry, can you hear this siren going off? This is...
It's New York, right?
It's New York, yeah, and I live on a busy street. But I suppose that's actually a very good example, because you know, we have created a model in which some people are deemed to be essential, like health workers, and their you know, movement doesn't align with other people's, but also people like farm workers, people who work in meat packing plants, you know, other industries that rely very heavily on people of color and often undocumented people to work in those spaces. And so we have this system that is actually quite parallel to the kind of past system that existed in this moment in Senegal, where you know, some kinds of labor is deemed very important for the continuation of different economic activities, and those people are often put at risk by that. And the other tension that I want to mention, because I think it is a bit, it's counterintuitive, I think, for the US in the moment, is that there was a lot of tension between colonial officials, that's to say political administrators, and the doctors who worked for the Colonial Health Service. And I think that our assumption might be that doctors, with their, you know, attention to the Hippocratic Oath, would be especially, you know, caring towards people who might be sick. But actually in Senegal, the doctors were the advocates for the harshest policies, the razing of people's homes. They advocated, you know, firing on protesters of these policies. And it was the political administrators who were more interested in trying to work with local elites, such as religious leaders, to create community, I think you would say in the public health parlance, adherence to these public health policies. So that's something that I think, you know, flips a little bit our expected idea of the response to a disease.
So you mentioned protests there, and how did the Senegalese people respond to public health measures against the plague? I mean, as you noted, some of them were quite coercive in terms of the use of state power.
Yeah, certainly. Many of them were. And there was a huge backlash or protest movement by Senegalese people. The first thing to note that's quite distinct about these two cities in Senegal is that they had a very different system of political control than other parts of the French Empire in Africa and elsewhere. So Dakar and Saint-Louis were two of four urban spaces, coastal urban spaces that are known as the Quatre Communes, and they had been colonized or had contact with France much earlier than other parts of Africa. And in the 19th century, there were a series of political reforms within France, which brought the existing colonies into the national territory. And the Quatre Communes were part of that. So the residents of the Quatre Communes were citizens of France, and they technically had the right to vote in most cases. And there were, you know, not all of the citizens were able to vote, but some were, which made it very distinct compared to other colonies and territories of France. And right before the plague outbreak, the first African delegate was elected from the Quatre Communes to the French National Assembly. And his name was Blaise Diagne, and his election was hotly contested. The Europeans living in these Senegalese communities did not want to elect him. And he won. And, nearly immediately after that was the plague outbreak. And so for a lot of Senegalese people, they understood the responses of the health administration to actually be punitive political responses to the election of Blaise Diagne. And this made people very skeptical of the public health interventions, aside from their coercive nature. And there was even a rumor that the vaccination process was going to be used to assassinate Blaise Diagne. And there's, I think a lot of logic behind that rumor. There's no evidence of that, but there's a clear political logic behind it. The response to the plague was much bigger and more intense than responses to previous disease outbreaks, such as yellow fever epidemics. There was actually a lot of commercial competition between the Métis, mixed race, African and Lebanese and Syrian merchants and European merchants. And, one of that population was not being restricted in the same way as the others. And a number of people on the public health board had been very, very public in their dislike of Blaise Diagne during the electoral campaign. So people were quite skeptical of the public health intervention because of that political background. Additionally, the policy to displace people and destroy their homes, caused immense anger and frustration and sadness for Senegalese people. And in Dakar, people really understood this to be a continuation of the process of the expropriation of Lebu land. And Lebu were the community who had been living on this peninsula where Dakar is located prior to French. I suppose the French had been there for a long time, but that was the community that had been living there. And so in response to, these attempts to displace people and move them into other, temporary housing, people, armed themselves with machetes and knives and tried to protect their homes, in some cases quite successfully. And there were also a number of general strikes. So in Dakar, there was a general strike, which was involved a lot of women, which I think is quite interesting. So the general strike, fishermen, market women who sold vegetables and fish and other kinds of foodstuff, and people who sold poultry went on a 4-day strike, which is actually would have been very disruptive because most people purchased their food the day of. And this was recognized as kind of one of the first popular strike actions by colonial officials. They were surprised by it and they recognized it as something that was kind of a new form of political mobilization. And in 1918 in Saint Louis, when there was a plague outbreak there, fisherwomen also went on strike and they refused to sell their wares. And in that case, the community that was really being targeted by these removal campaigns and the harshest public health measures was a fisher people community that existed on the kind of most coastward side of the Saint Louis town. There's like a barrier island that is inhabited in that town. So that's where that community lived. And so there's quite a lot of kind of like large scale political action that occurs from people's frustration over the public health policies. And in some cases, the colonial state actually was quite receptive and tried to modify their responses. And this was largely because during World War I, they wanted to continue to recruit African soldiers, and they were also concerned about a kind of pan-Muslim community. And because the residents of Saint Louis and Dakar were primarily Muslim, they wanted to, they didn't want to kind of create bad press for themselves in a context where they were fighting, a Muslim polity. So that's kind of interesting. The global dynamic actually may have made them slightly more receptive to some of the protests. Not in all cases, certainly. Obviously, there was an incredible amount of violence that was practiced against Senegalese people, but there were these kind of global dynamics happening related to World War I.
Right, the attention to military readiness and the need for colonial troops. Yeah, I'm always so intrigued by the role of market women in protests in many different contexts. I mean, we can think even of the French Revolution and then throughout in a number of different colonial contexts. So did the Senegalese people respond to the disease in any other ways?
Well, the disease was, a new disease actually for Senegalese people as well, or certainly there had never been an epidemic of this scale. So people were also concerned by it. And I think one of the things that, is important to think about is that actually there were like significant, there were many different African populations in Dakar at that time and in Saint Louis, but the evidence that I'm thinking of right now is mostly about Dakar. And in Dakar, the Lebu community was quite skeptical of other African communities, such as Fulbe or Fulani pastoralists, who they identified as kind of other and as more likely to be carriers of disease. So there was a little bit of this narrative around the other is the carrier of the disease, which existed even between different African communities, as well as between the European colonial apparatus and Europeans living in Dakar and African communities.
So, so much of what we know about modern Africa comes from colonial archives, right? So we get a view of modern Africa through European sources. And one of the things that I find so fascinating about your work and your dissertation is its focus on local expertise. So I'm wondering if we can maybe shift a little bit just from Senegal to Mali, or perhaps bring in both sides to get a sense of where local specialists, and in particular women's expertise, where has that fit in public health systems historically in French West Africa?
I'm so glad that you mentioned the issue of sources, because that is a real issue. And actually a lot of the writing about the plague epidemic in Senegal to date is really writing about the French response and the response of African residents to the French campaigns. But there's not that much that there's not as much that really talks about, for example, the response of indigenous healers to the plague, which would have been a new disease for those healers. So there, in India, there actually is some scholarship on the way in which different practitioners in India incorporated plague into the diagnostic systems which existed in Ayurvedic and Unani medicine, and also took part in kind of publicizing public health interventions. In Senegal, I haven't read in any case research that focuses on that, but there certainly was a very rich therapeutic tradition in Senegal and in Mali that involved both men and women healers. And one of the interesting things about the kinds of responses to disease that were available to people in Senegal and people in Mali was that the response to the disease often included a spiritual component or a component that we might think of as a psychosocial component. So often the same healers would be consulted for issues related to problems with the body, but also issues that are related to problems in well-being generally, such as inability to get a job, or problems with fertility. So of course there's specializations within, there are people who specialize in different kinds of treatment, but in general there is more of a connection between the social elements of someone's life and the physical elements of someone's life in the way that people sought out care and healing, as well as preventive treatment. And in Senegal and in Mali, there's a rich history of Islamic medicine, because many communities in those countries were Muslim, dating back 1,000 years. And a lot of the techniques that people sought out to treat and prevent illness involved the recitation of prayer and involved different kinds of amulets which relied on verses from the Quran, and sought out the expertise of people who were kind of religious healers and religious specialists at the same time. In terms of women, which is the subject of my own research, there's again a rich history of expertise that deals with subjects that kind of expand our idea of what healing might be. So women who attended childbirth in Mali, for example, also provided care for infants. So there's a sense that the process of having children is something that is not just related to the moment of pregnancy, the 9 months of pregnancy, but that involves infant care as well. And I think that we might be seeing a little bit of that now. There's this new concept of the fourth trimester, or perhaps, it's coming, I think, to there's a critical mass of discussion about the fourth trimester, which is somewhat reflected in the way in which specialists who dealt with pregnancy could also respond to infant health. Those midwives also were involved in providing advice during pregnancy with the idea that, just as we have idea of prenatal care affects postnatal health, there was a similar idea that what someone did during their pregnancy would affect the health of the baby after birth. But they had somewhat different ideas of what that might be. So there were often in Mali restrictions on how much women should eat or what they should eat during pregnancy. And the goal of those restrictions, which were later very contested by biomedical personnel, was to maintain a low birth weight for the baby, with the idea that that would facilitate an easy labor and delivery, which is a moment that's very risky for women and potentially for the baby as it's being born. So, there's a quite rich repertoire of ideas about how to have healthy children, which has this long span of time. That took us on a bit of a tangent, I think, but there's certainly a rich history of therapeutic knowledge, which involved a lot of herbal medicine, as well as these other techniques that I mentioned, like the use of amulets and prayer.
But it might have been a tangent, but it's also fascinating. And thank you, Devin, for this really interesting discussion. I'm looking forward to talking with you more about these issues and about your work. It's really interesting.
Thank you as well.
And thanks to all the viewers out there. We hope that you enjoyed this summer web series. We're planning a History in the Headlines event for early in the semester, which will tie together some of these issues that we've been discussing over the summer, and we hope that we'll see you there. We'll announce that over our social media channels. And until then, you can catch up on all our Viral Histories videos on our YouTube channel. Thanks very much. Bye-bye.